Hello, welcome everyone to the Master ECG series. I'm Dr. Patil and we are continuing the Master ECG series. We are into the lecture number 2. Today we are going to learn about the determination of axis, the cardiac axis on the ECG. In the previous module, we have understood the basics of ECG. If you have not gone through it, I would recommend that go through the previous module before you come to the current module. Otherwise, current module may not make much sense to you. Okay. So, now, what is cardiac axis? That's the first thing that we need to understand. Only when we have a conceptual idea of what is cardiac axis, we will be able to understand how to determine the axis and what is its clinical relevance. Okay. So, what is cardiac axis? Now, we know that there is something called as SA node, AV node, His bundle, Purkinje fibers, bundle branches, which are involved in conduction of electrical impulses throughout the cardiac myocardium for the sake of its contraction. Okay. So, now the flow of the electricity is flowing in multiple directions. Right now, when I look at it, from the AV node, it is going into His bundle, then bundle branches. From the bundle branches, it is going towards the right ventricle. It is also going towards the left ventricle. Now, can I say that there is multi-directional flow of electricity? When there is multi-directional flow of electricity, can I determine the net vector of the flow? For example, let us say this is a stone. Okay, and we have tied a rope to the stone and one person is pulling in this direction, another person is pulling in this direction. So in which direction the stone is going to move? Like heart, electricity is moving to the right ventricle, it is moving to the left ventricle. So what is the net direction of the flow of electricity? If the stone is being pulled in this and this direction, in what direction the stone is actually going to move? Right, so the stone is going to move in this direction as well as this direction. So the net direction of movement will be somewhere here or somewhere here, depending on which direction is exerting the maximum pull, right? So if this direction is exerting maximum pull, the stone will move somewhat in this direction. And if we are exerting maximum pull in this direction, then the stone will move somewhat in this direction. So that net directional vector is what is the axis. So what is the cardiac axis? Cardiac axis refers to the net direction of flow of electrical impulse during cardiac cycle. So when electricity is moving into the right ventricle, into the left ventricle, what is the net vector? Now we all understand that left ventricle is a most muscular chamber of the heart, right? If you have cut the heart during the dissection and you have seen it, we know that the left ventricle is most muscular. So generally the direction is more towards the left ventricle. That is the net direction of flow. So today we are going to learn how to determine what is the net direction of flow. Is it going towards left? Is it going towards the right? What is the exact axis of the direction? Okay. Now to be able to understand that axis, now you may be thinking, sir, why should we know the axis? Now why the axis is slightly towards the left ventricle? Because left ventricle is most muscular, so more electricity goes towards the left ventricle. But what if I develop a right ventricular hypertrophy? Now the right becomes more muscular, so more electricity moves towards right ventricle. So in that case, the axis is now directed, the net axis of electrical flow. Electricity is going to left as well, but the net axis is directed towards the right. So that helps me to think of the possibility of some pathology of the right ventricle, right? Okay. So now to be able to understand how we can determine the axis, we need to understand the ECG leads. We know that the standard ECG carries 12 leads. Out of those 12 leads, there are bipolar limb leads, augmented limb leads, and precordial leads. So we have 6 precordial leads, 3 augmented limb leads, and 3 bipolar limb leads. The 6 precordial leads, we will name them as V1, V2, V3, V4, V5, and V6. Then augmented limb leads, we will name them as AVF, AVL, and AVR. A refers to augmented. And then bipolar limb leads, we will label them as 1, 2, and 3. Okay. Now what these leads are doing? The leads are measuring the potential difference between 2 points. That is the basic concept of electricity. They are measuring the potential difference between the 2 points. Okay. Like for example, if I place 2 electrodes, one on the right shoulder, another on the left shoulder, I will make one electrode as negative electrode, the other as positive electrode. Right? Now the flow of electricity will be measured, or the potential difference between these two leads will be measured by the device. Okay. Now, why are we calling these 1, 2 and 3 as the bipolar limb leads? In the bipolar limb leads, what do is, we place the electrodes in 2 positions. Like for example, if I put a negative electrode on the right hand and a positive electrode on the left hand. Okay, so now I have 2 electrodes and I am measuring the potential difference between these 2 points. Okay, when I measure the potential difference between these 2 points, I am going to call it as lead 1. But we should always remember that we also place one more electrode on the left leg. We do place one more electrode on the right leg, which we are going to call it as the grounding electrode or earthing electrode. So normally we place 3 electrodes for the measurement of potential difference between 2 limb leads. So one is the left leg, and then right hand is acting as negative electrode, left hand is acting as the positive electrode, and we are looking at the flow of electrical impulse or the potential difference between right hand and left hand. Now, what is this telling me about? We have to only think of one thing. Think of placement of a camera, right? Let us say I am placing a camera here. Where do I place the camera? If I am putting a negative electrode on the right hand and a positive electrode on the left hand, wherever I place the positive electrode, you can presume it as the lead being placed there. So indirectly I can say I'm looking at the heart from this direction. When I have placed the lead 1 here, I'm looking at the heart from this direction. So this is where I have the heart, right? So I'm looking at the heart from this direction. Okay. Similarly, for the lead 2, right hand is going to act as negative and the left leg is going to act as the positive. So you can presume that the lead 2, if the heart is here, I have placed the camera in the patient's left leg. I am sitting in the patient's left leg and I am looking at the heart. And for lead 3, the left hand acts as the negative and the left leg acts as the positive. Left leg acts as the positive. That is our lead 3. So if heart is here, I am again looking at the heart from this direction. Okay, so I hope you are understanding. Each lead is actually looking at heart in one direction. So now I understand that limb leads are called as limb leads because the electrodes are placed on the limbs, right? Then why the precordial leads are called as precordial leads? The precordial leads are called as precordial leads because the electrodes are placed on the chest. Now why should I have limb leads and the precordial leads? So to understand that, let us presume that this is my heart. Okay. Now this heart, if I see in the frontal plane, means if I am seeing from the top or from the side. To see from the side or top, that is the frontal plane, right? Like you have seen the chest X-ray. The X-ray will have the lungs on the side, heart at the center. That is the frontal plane. So when I see the heart on the frontal plane, the limb leads will help me to see that. But if I want to see the heart in the horizontal plane, like if you have seen the CT thorax horizontal sections are taken. So if I want to see heart in the horizontal plane, the precordial leads help me. So precordial leads are helping me to see the heart in the horizontal plane. See heart in horizontal plane. And the limb leads see heart in frontal plane. See heart in frontal plane. Okay. Now bipolar leads, I understood why they are called as bipolar, because one limb acts as negative pole, another acts as positive pole, and we are measuring the net potential difference between those 2 points. Now then, why these augmented limb leads are called as augmented leads? So for the bipolar leads, what we were doing, we were using two limbs, as one as negative and another as positive. But in the augmented leads, what do we do is, of course, we have placed one electrode on the right hand, one on the left hand, and one in the left leg. Right leg will also have an electrode, which is the grounding electrode. Now here, instead of measuring the potential difference between the two limbs, what we are doing is we are measuring the potential difference between one limb and the net of other two limbs. Like, again, if you're not able to understand, let me tell you. Okay, I will give you a simple example. If this is right hand, this is left hand, and this is left leg, right? I will be placing 3 electrodes between these. So in case of the regular bipolar limb leads, I am measuring the potential difference between right hand and left hand, right? Or the left leg and left hand. This is how I am making the measurement of potential difference. But in the augmented limb leads, what I do is I will use 2 leads as the negative and one as the positive. So then these two are negative, these 2 leads are negative, and this is going to be positive. So these two will sum up, and the net direction of flow will be towards the sum of these two will be flowing towards the positive electrode. So now I'm adding these two, that's why it becomes increase in terms of the potential difference, it becomes increase. So we call it as augmented. So waveforms become relatively bigger, more clear. That's why it is called as augmented limb leads. So if I'm using between these 3, if I'm using the foot as the positive electrode, right arm and left arm is negative and left foot is positive electrode, then I will call it as AVF. Why it is F? F because it is positive. F is for the foot. Foot is the positive electrode. If I have negative as my right arm and the left foot, that is foot, as negatives, and the left arm as positive, then I will call it as AVL, right? Why it is L? The left arm is positive. And if I'm using left arm and left leg as the negatives and I'm using right arm as the positive, then we will call it as AVR. Why R? Because right arm is positive lead here. Now all these leads, right, the regular limb leads, the standard bipolar leads, as well as the augmented limb leads, they are looking at the heart in the frontal plane, and we can gauge from this lead placement only in which direction they are looking at. Whichever direction has the positive electrode, right, they are looking at the heart from that direction. Just to give you an example, let us say I have my heart here. Now this heart has an inferior surface, right? It has a lateral surface. This is the lateral side of the heart, this is the inferior surface of the heart. So now you should tell me, this lead AVF, here is the camera placed. So in what direction it is looking? Is it looking at inferior side or is it looking at the lateral wall of the heart? What is it looking at? Is it looking at inferior side or is it looking at the lateral side? Wherever I have the positive electrode, the camera is placed there. That's the basic understanding we should have. So don't you think AVF is looking at the inferior lead, right? On the other hand, if I look at the AVL, the camera is placed here, right? My heart is here. So what is it looking at? It is looking at the lateral wall of the heart. So if anything is wrong with the lateral wall, right, I should be looking into lead AVL. If I want to see anything wrong with the inferior wall, I should be looking at lead AVF. Okay. Now similarly AVR, right? The camera is placed here. The camera is placed here. It is heart is here, right? This is where I have the left ventricle. So it is looking at the left ventricle from the opposite direction. The current is flowing in this direction, right? The current is flowing usually in this direction, and it is looking at that heart in the opposite direction. So that is why AVR, if you look at any ECG, the AVR will have predominantly a negative deflection. The waveform will be predominantly negative in the AVR because it is looking from the opposite direction towards the heart. Okay. Now similarly, again, if I look at the lead 2 and 3, right, in what direction they are looking at? Lead 2 and 3. what is the direction of look for lead 2 and 3? The camera is placed on the positive leads. So what is the direction? They are looking towards the inferior wall again. So that's why lead 2, 3 and AVF are our inferior leads. They are the leads for the inferior wall of the heart. Okay. We have not actually placed the camera. It's just the electrode. But because the electrical impulse is heading towards this, it appears like we are looking towards the heart from that side. Just to imagine, like I am standing here, there is a person far away. If he starts running towards me, right, it will appear like he's coming towards me. If he goes in the opposite direction, the distance between me and that person goes on increasing. So he is making a negative move. If he is coming towards me, he is making a positive move. So we are making a positive move towards the positive electrodes. That's why we say camera is placed here. So we are trying to look at the heart from this direction, whether the electrical impulse is coming towards it or it is going away. If it is coming towards it, I will get a positive deflection. If it is going away from it, I will get a negative deflection. Okay, so now you should tell me, lead 1, the camera is placed here. So in what direction it is looking at? It is looking at the lateral side of the heart, right? Okay. Then what about the AVL? The heart is here, right? The camera is placed here. So again, this is also looking at the lateral side of the heart. So 1 and AVL are for the lateral wall. 2, 3 AVF are for the inferior wall of the heart. Okay. Now then, why do I need the chest leads? Chest leads are primarily meant for assessing the electrical activity of the left ventricle. Primarily meant for assessing the electrical activity of left ventricle. So we will place the leads on the precordium or on the chest. So when I place 6 leads, those leads will be labeled as V1, V2, V3, V4, V5 and V6. Okay. Now when I place leads for the precordial leads, heart acts as the negative pole and the lead acts as the positive pole. So the electrical impulse is moving from heart towards the lead. I am not using 2 poles here, right? Only for the bipolar limb leads, we have 2 electrodes. For the augmented limb leads, we are using the 2 limbs as the negatives and 1 limb as the positive. But here, heart acts as the base and positive electrodes are the electrodes that we are placing. So they are looking at heart and the electrical impulse movement. So when I see this picture, right, what do we notice? V1 and V2, they are looking towards what? They are looking towards the septum, interventricular septum. See, I have a right ventricle of the heart. I have interventricular septum. I have left ventricle. The left ventricle forms the most part of my anterior wall, right? When I look at the sternum and look at the heart, first thing that appears clearly to me is the left ventricle. Left ventricle forms the major part of the anterior wall of the heart, right? So then can I say that V1 and V2 are looking at the interventricular septum, or I can call them as septal leads, right? These are septal leads because they're looking at the septum. And V3 and V4 are looking at the anterior wall, which is part of the left ventricle, right? So they're looking at the anterior wall of the heart. Remember, the precordial leads are looking at the heart in the horizontal plane, not in the frontal or the vertical plane. The limb leads look at the heart in the frontal or the vertical plane. And then V5 and V6, they are looking at the heart from the lateral side, right? They are looking at the heart in the lateral view, lateral wall. So now let us summarize all that we have studied about the bipolar limb leads, augmented limb leads and precordial leads and their point of view, right? So the summary is lead 1, camera is here, right? Lead 1 is looking at the lateral wall. Lead 2, camera is here, it is looking at the inferior wall. Lead 3, camera is here, again it is looking at the inferior wall. Okay. AVF, camera is here, it is looking at the inferior wall. AVL, the camera is here, right? It is looking at the lateral wall. And AVR, it is looking at the left ventricle from the opposite direction, right? So let us summarize all the leads in simple terms. So lead 2-3 AVF, we learned that it is looking at the inferior wall. That is the point of view of the lead 2-3 AVF. So if I have any problem in the inferior wall, where should I find it? I should find it in the inferior leads. Okay. Now in the ECG, we do get something called as reciprocal leads. Now what do I mean by reciprocal leads? Okay. Reciprocal leads are the leads which are looking at the same part of the heart in a diagonally opposite direction, right? I'll try to brief it. Now let us say I'm looking at lead 1 and AVL. Lead 1 is looking at heart from this direction, right? From top to this direction. And lead 2, as you see here, lead 2 is looking in this direction from bottom upwards. This is from top left to downwards. So they're looking at the diagonally opposite direction, right? For example, the lead 1 is looking at directly at the lateral wall and indirectly the back of the inferior wall. It is looking at the back side of the inferior wall. Then lead 1 is looking at the directly to the lateral wall but indirectly the back of inferior wall. Similarly, lead 2 is looking at the inferior wall but indirectly the back of the lateral wall. So because they're looking, like, just to imagine, if I place the camera here, right? Let us say this is a transparent glass. If I say place a camera here, it is directly looking at this side and it is looking at the back of the other side, right? So a lead which is looking at back of something, we will call them as reciprocal leads. So what are the reciprocal leads for the 2-3 AVF? It is the 1 and AVL. So 1 and AVL act as the reciprocal leads. 1 and AVL act as reciprocal leads for 2-3 AVF. So any waveform which appears positive in 2-3 AVF may appear negative in 1 and AVL because they are diagonally placed in opposite direction. Okay. So now 1 AVL and V5, V6. Remember, 1 is looking at lateral wall, camera here, right? AVL, camera here, it is looking at the lateral wall. And then V5, V6, right? Camera here and here, they are also looking at the lateral wall. 1 and AVL, the higher portion of the lateral wall, and V5, V6, lower portion of the lateral wall. So we will call 1 AVL, V5, V6 as the lateral wall leads. Lateral wall leads. And because here I have 1 and AVL, 2-3 AVF will be reciprocal to it, right? Because they are looking at each other in the opposite direction. So 2-3 AVF will be reciprocal leads for 1 and AVL. What is the benefit of third lead in bipolar limb leads where there isn't any positive electrodes? Or that is grounding. Grounding in the sense, you might know that whenever we have electrical connections in the home also, there is a earthing electrode, right? So that background electrical noise, because heart is not the only electrical activity that is happening in the body, right? There are neurons and various other potential differences. It takes them away to the ground. So we should always have a grounding electrode for all electrical systems. Even at your home, electrical cables will have one cable as a grounding cable. Okay. Then V1 and V2. V1 and V2 are looking at the interventricular septum. So if there is any problem in the septum, right? Like if I have a septal MI, then I will see V1 and V2 showing the changes. But because there is nothing looking at the septum from the opposite direction, I don't have the reciprocal leads. Okay. And then V3 and V4 are for the anterior wall of the heart. They are for the anterior wall of the heart. See here, V3, V4 are for the anterior. Of course, I have a posterior wall of the heart. And remember, in this 12 lead ECG, there is not much of representation for the right ventricle. We have not placed leads for the right ventricle. If I suspect that right ventricle is having a problem, 12 leads are not enough. I need to have additional leads for the right ventricle. Similarly, if I suspect there is something wrong with the posterior wall, then 12 leads are not enough. I need to place leads behind the patient's back and then record the ECG. That we will discuss when we go to MI. Okay, so now we are just getting acquainted with the leads. If I'm placing posterior leads, then those will be called as V7, V8 and V9. 3 extra leads for the posterior wall if I'm placing it. And because V3 and V4 are looking at the anterior wall directly and posterior wall indirectly, they will become reciprocal to each other. Posterior leads placed and the anterior leads will be reciprocal to each other. This is a basic point of view of leads. This is one table that you need to be familiar with. You don't need to actually remember all these images. All these images are only to understand this table. You have to literally memorize this. Once you know this table, ECG becomes much more easier. Like for example, if I say that there is ST elevation in 2-3 AVF, now you know that the patient has problem or MI involving the inferior wall. If I say that there is ST elevation in V1, V2, now I know that patient has got septal MI. If there is ST elevation in V3, V4, I know patient has got anterior wall MI, right? Okay. So now having understood that leads have points of view, right? Each lead is looking at heart in one direction, right? And that direction will tell me which wall of the heart it is looking at. Now having understood that, we will come to the real crux, that is the determination of axis. So when electrical impulse moves in the heart, it is moving in multiple directions, right? It started in the SA node, right? It is like on the right side of the body. Then it is moving towards ventricle, right? Left and right ventricle. So it is moving from right to downwards, towards left and towards right. But what is the net axis? Okay, I think you're not able to see it. SA node sends an electrical impulse. It moves down to AV node. From there, it is going to the left ventricle as well as right ventricle. But what is the net direction? Is it going more towards right? Is it going towards left? Is it going more towards up? What is the net vector? That is what we try to determine when we calculate the axis. There are so many methods for calculation of the axis. Okay, but the most accurate method is isoelectric lead method, which is based on 3 principles. What are the principles? For the determination of axis, we are looking at the limb leads. We are not looking at the precordial leads. So V1, V2, V3, V4, V5, V6 out from our mind. We are only thinking of the bipolar limb leads and augmented limb leads. Bipolar limb leads are 1, 2, 3. Augmented are AVL, AVF, AVR. Okay. So the first principle is the QRS. If it is positive in any given lead, right? Pick up any lead. In that, if the QRS is positive, the axis is towards that direction, not exactly in the same direction, but it is towards that direction. Like for example, if I pick up, let us say lead 1 is looking at the lateral side of the heart, right? So if the QRS is positive in lead 1, that means the axis is directed towards lead 1. Okay, but if I pick up lead 1 and I notice that the QRS is negative, that means the axis is away from the lead 1. That is a basic understanding. If the QRS is positive, the axis is in similar direction. If QRS is negative, the axis is in the opposite direction. Now, if I know that, how will I get to know what is the exact axis? So for that, I have to remember. The method is called as isoelectric lead method, and the point to remember is in the 6 limb leads. 6 limb leads are 1, 2, 3. AVL, AVF, AVR. In the 6 limb leads, I have to identify one lead which has equiphasic QRS. Now we will try to understand what do I mean by equiphasic QRS. But for that, let us go through an ECG. Okay, now here is the ECG. When I see this ECG, each complex has a QRS complex, right? Each limb lead has a QRS complex. Like lead 1, there is an upright R. As you see here, there is an upright R and a negative S wave. Okay. Then when I look at the AVR, I have a predominant negative S wave. When I look at AVL, I have predominant negative S wave. When I look at lead 2, I have predominant positive R wave. Lead 3, also I have predominant positive R wave. Right? AVF, I have predominant positive R wave. So here I will say QRS net is positive because R is bigger than the S wave. Here also it is positive because R is bigger than S. S is the negative wave, right? Then in AVR, ES is predominant. So then it is a QRS is net negative. QRS is net negative. So first thing I have to do is I have to find one lead where the QRS is equiphasic, means the R and S appear roughly similar. I have to find that lead. So in this ECG, which lead shows R and S are almost equal? Is it lead 1? Is it AVR? Is it lead 2? Or is it AVL, lead 3 or AVF? Which one is showing R as equivalent? I'll come to that. I'll come to that. So lead 1, it is equiphasic, right? So we have to identify which lead the QRS is equiphasic. R and S are equal. Okay. And the axis of deflection is exactly 90 degree to this. Whichever lead is showing equiphasic QRS, the net axis is exactly 90 degree to it. So now how will I identify what is the 90 degree lead, right? So now just look at this. Where did you see the equiphasic wave? You saw the equiphasic wave in lead 1, right? So from this plane of arrangement, we will identify which lead is 90 degree to the lead 1. So lead 1 is this, right? The black line. Which lead is exactly 90 degree to the lead 1? It is AVF, right? 90 degree to lead 1 is AVF. So the axis is in the direction of AVF. Now what I should do? In the AVF, whether QRS is negative or positive, I have to see. So now let us go back to the ECG. So in the AVF, the direction is positive, means predominantly R or predominantly S. What is it? In AVF, what is it? In the AVF, it is predominantly positive, upright. So in this hexaxial plane, I have to see which side is positive 90 degree. So that means whatever ECG we saw, the axis is exactly positive 90 degree. Okay. The same method can be followed for any ECG, right? So let me summarize the steps again. First thing I have to do is identify among the 6 limb leads, identify one lead which has equiphasic QRS, right? R and S are equal. Now I have to identify which lead is placed at 90 degree to it from this hexaxial reference system. We call this as hexaxial reference system. You don't need to have a picture in mind. You can easily remember it. I'll come to that point. And once I figure out which lead is 90 degree to this particular lead where there is equiphasic QRS, now I have to see whether the QRS is net positive or net negative. Means R is bigger means positive, S is bigger means negative. So if the S is bigger, that means the axis will become minus 90 degree. If the R is bigger, the axis will become plus 90 degree. That is how we determine the axis. Now what is the normal axis? Normal axis lies between minus 30 degree to plus 90 degree. This is the normal axis. Now why the axis is directed in this direction? Because where is the left ventricle? Left ventricle is the most muscular organ that requires a maximum electricity. So more electricity flows towards the left ventricle, and the left ventricle is placed in this direction, right? That's why the net axis is usually between minus 30 degree to plus 90 degree. Minus 30 degree to plus 90 degree. Then minus 30 degree to minus 90 degree. We call it as left axis deviation. We call it as left axis deviation. The deviation has become more leftwards, right? If the electricity's net direction is more this, it has become more towards left. So we will call it as left axis deviation. And if the net direction is between 180 degree and minus 90 degree, we will call it as extreme axis. This will be called as extreme axis, because we are not expecting the electrical impulse to be moving in this direction until and unless there is a major pathology, right? So we will call this as extreme axis. This is extreme axis. And if the direction is between 180 degree and the 90 degree, it is more towards right ventricle, right? Electricity is more moving towards right ventricle. So then we will call it as right axis deviation. The right axis deviation. This will be right axis deviation. So typically when right ventricle becomes more muscular, electricity will come more towards right. So we'll have right axis deviation. If I have left ventricular hypertrophy, electricity will move more towards left. So we'll have left axis deviation, right? Okay, well, I hope we have a basic idea how to determine the axis. For determination of axis, what am I looking at? I am looking at the hexaxial reference system, which is actually the plotting of the direction of view of point of view of each leads of the limb lead system, right? The bipolar limb leads and the augmented limb leads. And then among the 6 limb leads, we are identifying one limb lead which is showing equal amount of R deflection and equal amount of the S deflection, equal positive, equal negative. And then we are finding which is the 90-degree lead to it, and the direction of the electrical impulse is exactly 90-degree to this lead. Okay, so let us do an example now. Okay, so we will take this example. You should tell me which lead is isophasic, right? Then we will see how to identify what is the axis. Which lead is isophasic here? Having equal distance travel of R and Q wave. Is it lead 1? Is it lead 2? Is it lead 3? Is it AVR? Is it AVL? Is it AVF? Okay. So let us look closely. So this lead 1 as well as lead 2 appear to be equiphasic, right? When you look closely, lead 1 and lead 2 both are equiphasic. Okay, so this is a little complex issue. When two leads are equiphasic, such lead is called as having indeterminate axis. We cannot determine the axis, but that is perfectly normal. Okay, so we'll ignore this. We will look at one more example. Okay, this is a very clear ECG image. Tell me which lead is isophasic. Which lead appears to be isophasic? Is it lead 1? Is it lead 2? See, this is lead 1. Is it isophasic? No. Is it AVR? No. Right? Is it lead 2? Yes. Lead 2 appears to be isophasic. Is it AVL? No. AVL is predominantly negative. Is it lead 3? No. Lead 3 is predominantly positive. So lead 2 is isophasic. Now what is the 90-degree lead for the lead 2? Right? We will go to the 6 hexaxial reference system. Okay. So let me draw the lead 2 in blue color, right? This is the lead 2. This is the lead 2. So what is exactly at 90-degree to lead 2? It is the AVL which cuts it at 90-degree to lead 2, right? AVL is cutting it at the 90-degree to lead 2. So then if isoelectric QRS is in lead 2, then the axis is exactly 90-degree to it, means at AVL. So now what I should do? I should see whether AVL is net positive. If AVL is positive, the direction is minus 30-degree. If AVL is negative, then the axis is plus 150-degree, right? Okay, so let us see in that case, what do I get here? AVL, right? So when you look at AVL, is it negative or positive? It is negative, right? So if it is negative, that means the axis is 150-degree. So is this normal axis? What is the normal axis? Normal axis is minus 32 plus 90-degree. So this falls in the right axis deviation, right? So this patient has got right axis deviation. So he may be having right ventricular hypertrophy or pulmonary embolism, some problem with the right side of the heart. That's why he has right axis deviation. Clear? So easy way to remember this 90-degree thing is, don't have to picturize this hexaxial reference system. All you have to remember is what are our inferior leads. Inferior leads are 2, 3 and AVF. These are our inferior leads, right? Now AVF, remember the first example we took was what was at 90-degree to lead 1. Lead 1 is looking at from left heart, right? It is looking at the heart. From left limb, it is looking at the heart. And AVF is looking at the heart from the left foot. So they are exactly at 90-degree. So that's the only point you have to remember. One is for the AVF. Okay. Then the lead at 90-degree to 3 is AVR. Easy to remember, right? When we say 3, we stress on R. R is AVR. And whatever is left is the AVL for lead 2. So as long as you remember this, all your axis determination is sorted, right? So first thing is, between these 6 leads, identify which one is isoelectric. Once you identify if one is isoelectric, I have to look at AVF. In AVF, if the QRS is positive, then I have to look at the AVF axis, the QRS, what degree it falls into, and if it is negative, what degree it falls into, right? Okay. So let us see some more examples from the previous ECGs if we have the images. Okay. So let us determine the axis in this ECG. Which lead appears to be equiphasic here? This is the image that we used in the previous class, right? Which one appears to be equiphasic here? The lead 1 appears to be equiphasic, right? The lead 1 appears to be equiphasic. And what is the opposite of lead 1? AVF, right? The 90 degree of lead 1 is AVF. And AVF, it is predominantly positive. So AVF is positive, then in the hexaxial reference system, it was pointing towards AVF positive means 90 degree. AVF negative means minus 90 degree. So I have AVF positive. So the axis is going towards 90 degree. So in this image, what is the axis? It is 90 degree. So is it normal or abnormal? Is it normal or abnormal? What is the normal axis? Minus 32 plus 90 degree. So it is at 90 degree. So we will count it as normal, right? So let us see if we can do that for other images. Okay, what about this? What about this? Which lead appears to be equiphasic? Is there any lead which is equiphasic in this? Okay, so what we will do is, there is no lead which appears to be equiphasic. One is also not equiphasic, right? S is quite smaller than R. So when the lead is not equiphasic, how to determine? So I will leave this small homework to you, how to determine when the lead is not equiphasic. But we will try to do it for the other leads. So here, which appears to be equiphasic in this ECG? In this ECG, clearly lead 1 appears to be equiphasic. So if one is equiphasic, its 90 degrees AVF. AVF is positive, means we have heart axis as 90 degree. Axis as 90 degree. Okay, so in this, which appears to be equiphasic? So in this again, nothing appears to be equiphasic, right? AVF appears to be equiphasic. So if AVF is equiphasic, what is that 90 degree to AVF? Remember, 2, 3 AVF. We should always keep in mind 2, 3 AVF. AVF के लिए 1, 3 के लिए AVR, R for 3, and for 2 AVL. So 1 is at 90 degree, right? So now I have to look at lead 1. So lead 1 is showing positive deflection. So in the hexaxial reference system, if the lead 1 is showing positive deflection, right? In the hexaxial reference system, if the lead 1 is showing positive deflection, it is 0 degree. So is it normal? Yes. Minus 30 to 90 degree is normal. So this axis is also normal. Okay. This we cannot determine. Okay. So that is going to be our approach to determination of axis. So I will leave 6 or 7 exercises for the determination of the axis in the PDF note. Try to determine the axis. In the next class, we will try to understand more complex ECGs where, like, the axis determination using the isoelectric lead method does not work. How do we determine the axis? Okay. If there are any doubt related to what we have discussed so far, let me take them. Kushi, okay. I will share the answers in the PDF. Mulchand, we will definitely go ahead with that. Anna, okay, see, if you're preparing for the FMG medicine, okay, see, whatever we have covered in the YouTube, it is a revision or a quick review. So it may not be able to give you the conceptual understanding behind many concepts. But to be able to deal with clinically oriented questions, you need to have little bit of conceptual understanding. So what I would suggest is at least the neurocardio parts, which are very much conceptual, and to some extent nephrology, go through the main videos. Rest of the things you can cover from YouTube, like the gastroenterology and rest of the nephrology, you can cover from the YouTube. Okay, MB, I didn't understand your question. How is going to help infarction? Which part at the end TT is same? I didn't understand your question. MBEG, how determination of axis helps. That's what, see, like we saw an ECG here, right, which has this ECG, all of you told me that it has right axis deviation. Why we came to the conclusion that this ECG has right axis deviation? Because here the isoelectric lead was lead 2 and the opposite of lead 2 is AVL, and in the AVL it is predominantly negative, so it goes towards the degree 150 degree according to the hexaxial reference system. So that means the electrical axis is directed at 150 degree. It is directed at 150 degree here, which is in the right axis. Why electricity should be moving towards the right side more? Ideally it should be moving towards the left ventricle, which is the most muscular ventricle. But the moment I know that it is moving towards the right side, I can suspect that there is something wrong with the right side of the heart, right? So patient may be having right ventricular hypertrophy. There are various causes for the right axis deviation. Right ventricular hypertrophy is one. We can have right axis deviation in the pulmonary embolism. We can have right axis deviation in patients with cor pulmonale. So we can suspect all those entities the moment I see right axis deviation on the ECG. Right. So especially in the acute scenarios where someone presented with sudden onset shortness of breath, and there is a history of flight travel, and I get an ECG done, and in the ECG I notice that there is right axis deviation. It triggers the suspicion of pulmonary embolism as a possibility, because in pulmonary embolism the axis can become right. Okay. Similarly, if the axis becomes left axis instead of the normal minus 30 to 90, I can suspect the left ventricular hypertrophy. So we can suspect various conditions based on the axis. So determination of axis helps us to suspect those conditions so that we can do more focused investigation. Like if I'm suspecting pulmonary embolism, I will go ahead with the D-dimer and the CT pulmonary angio or high resolution CT of the thorax. If I'm suspecting the hypertension induced left ventricular hypertrophy, I will go ahead with the echocardiography and then identify that indeed there is LVH. For all that reason, axis becomes a useful tool. Okay, so that's it today. So what we are going to do, we will have 6 to 7 exercises to cover the axis. Now in that, 2 or 3 exercises might seem difficult because you may not be able to identify the isoelectric leads. How to deal with that, we will address in the next. But meanwhile, you try from your end by going through the Google or whatever sources you have. And I'll discuss that in the next class. Okay, thank you all. Thank you. Thank you.